I was having problems walking, and I decided it was time to go see an orthopedic. And Dr. Rodriguez took an x-ray of my hip and told me that I needed to have a total hip replacement. I was astonished. At my age, a total hip replacement? And he explained to me that I had injured my hip and had worn the cartilage down, and my hip was actually bone on bone. My surgery was scheduled for April 2nd at Ocean Medical Center, and I was a little nervous. So I got to the hospital, and everyone treated me wonderfully, had the surgery, and believe it or not, with the nurses and the therapists, I was up an hour after my surgery walking. I didn't walk very far, but I walked.
Amazing. That was Kim you were just seeing. Now you're seeing a surgeon who actually does this work, Dr. Joseph Bogdan, who is chairman of the Department of Orthopedics, co-medical director of the Joint Replacement Program at Ocean Medical Center. Now that was Kim, and she had her work done by your colleague.
One of my partners, Dr. Rodriguez. He's
Okay.
one of my practice partners.
You have brought, I got to tell you, Doctor, we've had lots of clinicians in here over the years, and no one has ever brought a more elaborate, interesting, look at this, Steve Barcy, our camera, got, Steve, that's a good set of stuff, huh? Now, what are we looking at here? Because joint replacement surgery has expanded tremendously, right? Advancements?
Correct. I mean, there's advancements on a regular basis, and it's a big problem in society right now with regards to osteoarthritis. And our academy right now is talking about a 600% increase in the volume of cases that we may see over the next 20 years.
Why?
Just because of the baby boom population, and people are maintaining a very active lifestyle going forward, and they don't want to accept those limitations.
Do we want them sooner?
Yes. Patients don't want to compromise their quality of life at any point in time, and so they'll try everything that they can do short of surgery, but it may ultimately end up with surgery.
Let's do this. You want to try hip first?
Sure.
Let's do hip.
Sure.
Where's the hip?
So these are models, miniaturized models of a hip replacement. This would be an example of a healthy joint where your articular cartilage, which is the surface of the hip replacement, and the socket here are still in very good shape.
Okay, move in on that, Steve. This is good shape.
Yes.
Everything looks good there, right?
Correct.
Got it.
And then as time goes along, with wear and tear changes of the joint, you can develop moderate arthritis, which is where the joint starts to break down. The articular cartilage will start to wear and become worn out, erosive, and have holes or craters in it.
Is that the bone-on-bone stuff we're talking about?
You're getting there. You're
we're
getting
not
to that
bone-on-bone
point.
yet.
Not yet, but that's developing. And then when you get into the more severe stages is where you do get to that advanced osteoarthritis, or the joint wears down to where it's bone-on-bone. It's very hard, it's sclerotic.
Pain.
Pain. A lot of pain, a lot of limitation in your motion, and it's truly starting to affect your quality of life at that point in time.
Got it.
When the patients get to that point where it's really they're quite compromised, they then think about the options, whether they've gone through all the conservative options, or if it gets to the last resort, when it's affecting their quality of life, that's when they decide for a hip replacement or some type of joint reconstruction. And this would be an example of the metal stem that's implanted in the femur. And
that's
then,
a metal? That's metal?
Correct. That's a metal head. It could also be ceramic. And then there's a metal shell that goes into the acetabulum, and this is probably a better example of it. It looks similar to this. And then that gets fitted with this polyethylene liner.
That's polyethylene?
Correct. You could use either polyethylene or ceramic. Those are the two main surfaces that are used out there.
Right.
Metal is also an option, but there's been some problems with that.
And they move nicely together, right?
Correct. Well, that's locked into that shell.
That's locked in. Where's the
this would be
the
example
mobility
of
here?
the correct.
As I'm doing this, as I'm looking at this, who's a candidate, who's not?
So you'd go through the conservative treatment options of it. When
Right.
a patient presents, they have pain, they have limitations in their daily activities, they have the inability to stand or walk or enjoy activities like golf, tennis, or bike riding or jogging, and they present to the doctor's office to go through the various options. And you start out conservatively with whether it be anti-inflammatories, ambulatory aids, therapy modalities, weight reduction. All those things play a role in the conservative treatment initially. Then you get to the surgical options. You know, after you've maximized the conservative treatment modalities, when it's a quality of life issue for them, they then jump into the surgical arena.
Real quick, in the time we have, knee.
Knee. So
Show me knee.
same process with regards to the.
Can we get the hip out of the way?
The articular surface.
I don't want to break anything.
That's fine.
Thank God this isn't real. I just did. Sorry.
So
You got this? Thank God I'm not in the OR.
Same process where this is a normal appearing joint where your joint surface is
Healthy.
See,
that's
the ligaments, the cartilage, everything is intact.
Right.
With time and wear and tear, it starts to break down and it becomes more and more erosive.
Ouch. Now that's not good because
limits their motion, their activity. They have a lot of stiffness. They're limping. And then when you get to the final option, which is after you've maximized the conservative things, you get to the knee replacement, which is think of it as a surface replacement, where we're going in and removing the worn out surfaces of the joint and replacing it with either metal or polyethylene or ceramic.
Let me ask you something. The time we have left, Doctor. The advances
Correct.
in this technology, could you have shown me this 10 years ago?
We could have, but the materials have changed and improved significantly. The bearing surfaces have been improved upon so that we can improve the longevity of the implant. Also, the surgical approaches are better, where we're making a much smaller incision. You're improving the rehab potential. The whole goal is to get the patient up and mobile as quickly as possible.
And these are lasting how long?
20 plus years, we'd hope.
20 plus years.
Yes.
And do you think this is pretty much it or no?
No, there's improvements every year. There's improvement in design, the way that the implants are fixed to bone, the approaches that we take. I mean, similar for the hip, there's been advances in the approach from the standard kind of posterior approach to now people are trying to do the anterior approach, which improves their rehab and gets them out of the hospital a lot quicker.
For someone who like you who went into this field, this has got to be tremendously rewarding. I got to tell you. In the time we have left, people should check out, talk to the right doctor, get the right information. Not everyone's a candidate. Go conservative. You always say conservative,
Yes.
right?
It's very important. The key is patient education.
That's the key. That's why we're here. Dr. Bogdan, thank you
Bogdan.
so much for being here. We learned a lot.
Oh, thank you.
Thank you so much.
Yep.